Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome back Dana Lujan. She's a healthcare strategist. Today's Kevin MD article is direct primary care sustainable in a downturn? Dana, welcome back to the show.
Well, thank you, Dr. Fo, for having me.
All right. Tell us what this latest article is about.
So, this article was prompted by a very public debate around HSA eligibility for direct primary care membership. What caught my attention was not the debate itself, but the response to it. The conversation focused heavily on regulations and philosophy, but almost no one paused to examine the underlying economics. So, before continuing a broader employer discussion, I realized it was important to step back and clarify a foundational distinction. So, retail DPC and employer sponsored DPC operate under very different economic models, and treating them as interchangeable leads to confusion around affordability and sustainability.
Give us a distinction between those two models, just for some context before we talk about your article.
Okay, so with retail DPC, that's based on household discretionary income.
Hmm.
So, as long as your household income is stable month after month, then you're going to be able to afford the membership or subscription model for retail DPC. On the employer sponsored DPC, it's funded by your organizational strategy and benefit design. So who's paying always determines on, the stability of the type of economic model that you have for your plan.
So we've talked about retail DPC multiple times on this podcast, but for those who aren't familiar with that model, just give us a range of typical subscription prices for common retail DPC practices.
So you have, your single, one individual anywhere between $70 to $150 a month per person. Then you have your family, maybe it's two adults plus one child is $300. And then you tack on additional, which is like $45. It just really depends on which market you're in and what the provider is offering. So, and this, includes like, unlimited visits, no insurance billing. It's a very narrow plan. So you're looking at 600 patients. And if one of your patient calls in and needs to be seen right away, either they get seen that day, if not the next day.
So when it comes to an economic downturn, and for a segment of the population, this would classify as a downturn. Inflation is rising, the cost of pretty much everything is rising. How does that affect the viability of retail DPC practices?
So, so then you have to look at it as behavioral economics.
Yeah.
So behavioral economics explains how family prioritizes spending when budgets tighten, when discretionary incomes, contracts, preventive care subscriptions, as a family or even as an individual. Let's say if rent goes up $200 and my DPC plan is $150, and I'm not seeing a provider every single month, I'm going to say, okay, I'm not going to be part of the plan
Hmm.
because my rent came up. I need to put that money towards it. So there's those nuances, and because our society is so subscription out, that retail DPC becomes part of the how can I say it? Can we afford to cut it out? Do we
Hmm.
utilize it? When the economy is stable and when your income is stable, you can tolerate, oh, I don't see this doctor often, but we have a great relationship. They can't see me today, but they can see me in 2 days because, who knows, the doctor might be out on vacation or something. I don't know. So there's nuances that you're able to tolerate, but then when your budget starts tightening, that's whenever it starts becoming a little bit more, do we really need it or do we not?
How about from the perspective of the DPC practice itself? Does that mean they typically locate in areas that are more socioeconomically less affected by any economic downturns?
Yes. So, for instance, I believe we discussed about market analysis. So, if your office in a very, I don't, affluent neighborhood or a
Hmm.
neighborhood that even if the economy is not so great, they're still able to afford that subscription plan,
Hmm.
then you're okay. But let's say you're in a middle class, and when I say middle class, I don't mean upper class, middle class America. Middle class America right now is getting hit tremendously by this inflation.
Yeah. So, what are some levers that the DPC practice can potentially pull when it comes to economic downturns or if they find themselves in a middle class area? Is there anything financially they can do to help the financial viability of their practice?
Well, I think this is why retail, when the DPC, this is how they diversify is through employer contracting.
Hmm.
Small businesses, mid-sized businesses. So you're not just set on the retail DPC. If you ask most of these DPC providers, they prefer direct to consumer. Why? Is because it's simple. It's direct to consumer. When you start venturing out into the employer perspective, small business, depending on what type of small business they are, small to medium size, then you don't know what you're venturing into, what kind of accountability, what kind of paperwork. And when I say accountability, I don't mean on clinical. I mean on paperwork, quality metrics that the employer might set aside for that funding.
How difficult is it for a DPC practice to contract with an employer? You mentioned some bureaucracy, but for those who aren't familiar, I'm not familiar with this, so how difficult is it for a practice to find and contract with an employer?
Well, that's a very good question. So I know in my current in the market that I'm in, if if you can spend 5 to 10 hours a week, you can be able to find a small employer.
Hmm.
A small employer that either has, a high deductible plan or a small employer that probably doesn't have insurance for their employees, but would like to offer an incentive. This is kind of like a workaround, as well as medium-sized employers. So depending on the market you are in and how advantageous you are and the time you're able to find those small employers rather quickly. It doesn't happen overnight, but it does happen, depending on, so for instance, if it's a school district, with the school district, they put out the RFPs. Sometimes that can be within 90 days to 6 months, and then you're hauled in within the beginning of the year. So again, timing is of the essentials. If you are a very small business, meaning probably up to 100, you can kind of roll that in within 30 to 60 days.
So I know that you're a consultant and you help out DPC practices. So what are you advising them when it comes to retail versus employer? Are you advising them to do a hybrid, a little bit of both, so they compensate for each other? What kind of advice do you have for DPC practices that are just starting out?
For DPC practices that are just barely starting up, I tell them always let's do a hybrid right out the door. One being is because if we can get a small employer, and I actually look for ones that are under 25 employers, that's still an incentive and
Hmm.
that's still revenue that's coming through the door
Hmm.
while you're building up your retail side of the business. So I try to go both, and I'm very good at where the market's at. I can kind of cross like, okay, who do I know or how do I get through the door to kind of help with that client and trying to go for the employer.
Now, from the employer standpoint, what incentives do they have to choose a DPC practice versus a traditional menu of health options that most employers give their employees?
So, so let's take if you're a small employer with no insurance, that's an incentive for your employees because sometimes your employees might not have insurance at all. And even if they pay, $100 a month, or you take on, okay, I'm going to pay $50 a month, you're going to have to, collect, you pay out the $50 for that. That's still an incentive because now they have a doctor to go to when they're sick. It's not, they get to build up that relationship and that trust. If it's an employer that's mid-sized to large, a lot of the DPC physician will say, "Hey, we drive costs down." That's not actually true. What they do is help with utilization.
Hmm.
That's the number one benefactor with having a primary care as well as a DPC. You help with that utilization. Does it sometimes draw costs down? Yes. But does it always? No, because when you're looking at the bigger picture of healthcare, right now it's pricing. You can help with utilization, but you can't help with the hospital pricing or the pharmacy pricing.
So when it comes to the hybrid model that you suggest DPC practice take, approximately what percentage do you recommend? Is it 50-50? Is it skewed one way or the other towards retail versus contract? What would be an ideal mix?
Again, I think it really goes back to the provider and what they're looking for.
Hmm.
And the reason why I say that is because if you have, let's say, one employer that's 250, well, and you're thriving to 600, that's, pretty much a majority of your, and then you have to fit the rest of the retail. And let's say you have another employer that's another 250, well, then that's only 100 retail. But let's say these other employers decide, like, okay, well, we're going to relocate our business out to, the other side of America, then you lose 250.
Hmm.
So you have to kind of play it where the majority of your practice is pretty much retail, and then you have your employer contracts where it's a significant amount, but not to where it's that significant that if they decide to go a different way with their contracts, you're left.
Now, for those DPC practices that fail, especially during economic downturns, is simply the reason they just don't have the right mix of retail versus employer customers or patient base? Is this skewed too much one way or the other? What are you seeing as the main reason?
No, no, I think the reason why a lot of the DPCs I have failed within the first 2 to 3 years is because one, when they first started off, and I'm not speaking about the new doctors, it's, doctors who are transitioning, they probably didn't have a ramp up period of really solidifying their mix between retail and employer. So that's always the number one. Number two, market, because
Mhm.
again, if your market analysis is off, so let's say you're transitioning or you're a new provider and you're going into a market, but you notice six other DPCs all around you, that makes it very hard to obtain new patients because you're all after the same thing. And same employers, same thing. So that's number two. And number three, I've seen is the pricing because
Mhm.
sometimes I'll wonder whenever I see a DP, and I've seen it, oh, your price at 50. Okay, how's this happening? And then I see their menu and it is a menu. And I'm like, okay, so you're putting yourself at 50, then you have all this menu with different pricing. What are you trying to accomplish? So they're
Mhm.
not very, how is it? Their clarity is off.
Mhm.
You need clarity because, I'm not going into a restaurant to order. I'm trying to find a doctor to build that relationship and trust. So it's a mixture of things in that regards.
We're talking to Dana Lujan. She's a healthcare strategist. Today's Kevin MD article is direct primary care sustainable in a downturn? Dana, let's end with some take-home messages that you want to leave with the Kevin MD audience.
Yes, access improves care, but economics determines sustainability. Think like a CEO, validate like a CFO, and be clear about who's paying, who benefits, and how savings are captured.
Dana, as always, thank you so much for sharing your perspective and insight, and thanks again for coming back on the show.
Thank you for having me again.